Hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik NV, doing post-graduation in Emergency Medicine. In this video, we are going to discuss about hypokalemia. Okay, let's start our discussion with certain facts about potassium. Okay. So, potassium, as you know, it is a major intracellular cation of our body. Okay, major intracellular cation of our body. Okay, and for your knowledge, the major or most common extracellular cation is sodium. Okay, potassium is the major intracellular cation, while sodium is the most common extracellular cation. Okay, now the normal serum value of potassium is between 3.5 to 5.0 milliequivalents per liter. Okay, now the one more fact is like there is a relationship between pH and serum potassium value. Okay, as the serum pH decreases by 0.1, there will be an increase of serum potassium by 0.6. Okay, as the pH decreases, that the pH become acidic, there will be increase in potassium. The exact reverse thing happens in case of alkalosis. Okay, as pH increases, the potassium value decrease by 0.6. So the alkalosis decreases the serum potassium, while the acidosis increases serum potassium value. Okay, that's the relationship between pH and potassium value. Now moving on to our topic, hypokalemia proper. Okay, hypokalemia. So the hypokalemia is defined as a serum potassium concentration less than 3.5 milliequivalents per liter. Okay, now let's quickly move on to the causes of hypokalemia. So the causes. The major cause is transcellular shift. Okay, transcellular shift. So there are various triggers for transcellular shift of potassium. That is, potassium is shifting from extracellular compartment to intracellular compartment. So that's why the serum potassium concentration decreases. So the triggers include, first one is alkalosis, which we have already discussed. Alkalosis will decrease serum potassium value. Now the second cause is therapy or treatment with insulin. So okay, insulin also cause intracellular shift of potassium. Then beta agonist drugs with beta adrenergic property. Okay, and in case of periodic paralysis, that is the patient presenting with paralysis, there will be hypokalemic periodic paralysis. Hypokalemic periodic paralysis. Or maybe it is due to thyrotoxic. Okay, so there is a thyrotoxic hypokalemic periodic paralysis. Okay, here it is congenital, while the other one is thyrotoxic induced hypokalemic periodic paralysis. So these are the mechanism or triggers for transcellular shift of potassium. And the other causes include, the second cause is, it may be due to decreased intake. Okay, or the hypokalemia may be due to GI loss of potassium. GI, gastrointestinal loss of potassium, may be either due to vomiting, diarrhea, or malabsorption. Okay, or the loss can be through the renal system also. Renal loss, it may be due to either by diuretics or primary or secondary hyperaldosteronism. The mechanism of aldosterone is excretion of potassium and H+ ion and absorption of sodium and water. So the elevated aldosterone will increase the excretion of potassium. Okay, now the third cause is renal tubular acidosis. Okay, and it may be also seen in Barter's syndrome or Gentleman syndrome. The mechanism of Barter syndrome is like loop diuretics. Okay, and in Gentleman syndrome it is like thiazide diuretics. Okay, and the other cause may be loss in sweat, or the hypokalemia also seen in association with hypomagnesemia. Okay, so the hypomagnesemia, magnesium ion is required for absorption of potassium. Okay, these are the causes for hypokalemia. Now let's move on to clinical features of hypokalemia. Okay, with which all symptoms the patient with hypokalemia present to our department. Okay, the clinical features of hypokalemia usually starts at a serum concentration less than 2.5. Okay, at a range of 2.5 to 3.5, the patient may be asymptomatic in most of the cases, and the symptoms usually begins at a concentration less than 2.5. And let's see the system wise what all the symptoms with the patient presents. Okay, in cardiovascular system, there may be hypertension or orthostatic hypotension, or patient may have dysarrhythmias. Okay, dysarrhythmias. Now in this EVS, the ECG features of hypokalemia are very important, and it's a common questions in various exams. Okay, so the ECG features of hypokalemia include, first one is T wave flattening, QT prolongation, U waves. U waves are due to the delayed repolarization of Purkinje fibers and myocardium. Okay, or there may be ST depression. So these are the four important ECG findings in patient with hypokalemia. Okay, T wave flattening, QT prolongation, U waves, and ST depression. Now in neuromuscular system, patient may have weakness, fatigue, hyporeflexia, cramps, rhabdomyolysis. In GI system, patient may have vomiting and abdominal distension. Okay, and in renal system, the symptoms may be maybe because of increased ammonia production. There may be metabolic alkalemia and paradoxical aciduria. There may be nephrogenic diabetes insipidus. Okay, so these are the common clinical features that we can see in a patient with hypokalemia. Now, how to investigate a case of hypokalemia? Investigations. Okay, the investigation of hypokalemia actually starting from the history itself, because we have to get a cause for hypokalemia. Take a proper history, including medications, which all medications are patient is taking, and specifically look for whether there is any beta agonist, insulin, or diuretics. Okay, now the investigation what you have to take a ECG and look for the features which we have already discussed. Okay, like T wave flattening, ST depressions, or U waves, like that. Okay, and also you can take a ABG. Okay, and look for alkalosis, Okay, and you should take a spot urine electrolytes. Okay, it include urine sodium and urine potassium. Okay, now how to interpret with the urine potassium? You look for the urine potassium value. Okay, and if it is less than 10, okay, the potassium loss is not through the urine. There is some extra-renal mechanism for potassium loss. That is the interpretation. Okay, potassium loss is via extra-renal mechanism. That is other causes like transcellular shift or GI loss, or due to decreased dietary intake, etc. Okay, and if the urine potassium is more than 20 milliequivalents, then it is the potassium loss or cause of hypokalemia is due by renal loss only. Okay, So that is the one use of sport urine electrolyte. And the other use is there is something called transtubular potassium gradient. Okay, transtubular potassium gradient, and the equation for calculating transtubular potassium gradient is urine potassium multiplied by plasma osmolality divided by the plasma potassium multiplied by urine osmolality. Okay, with this equation we have to calculate transtubular potassium gradient. Okay, and the normal value of the transtubular potassium gradient is 8 to 9 milliequivalents per liter. Okay, and if it is less than 5, in a patient with hypokalemia, the interpretation is it is due to hyperaldosteronism. The hypokalemia is due to hyperaldosteronism. Okay, now if the patient with hypokalemia is presenting with a paralysis and you have calculated the transtubular potassium gradient and you got a value less than 3, okay, and the patient presented with a paralysis, then it is due to hypokalemic periodic paralysis. Hypokalemic periodic paralysis. Okay, so this is the use of this equation and the calculation of transtubular potassium gradient. Now, if you are not getting any cause for hypokalemia out of this with this investigations, then you have to go for another investigation, that is your calcium to phosphate ratio. Okay, the value should be obtained from sport urine. Okay, sport urine value of calcium to phosphate ratio, and if it is more than 1.7, the hypokalemia is due to thyrotoxic hypokalemic periodic paralysis. Okay, so this is how you have to investigate a patient with the hypokalemia. Now moving on to the management part. So in management part, there is an equation for calculating potassium deficit. Okay, you have to calculate the potassium deficit, and the equation is expected serum potassium minus measured serum potassium, okay, multiplied by intracellular fluid volume. Okay, this is the equation for potassium deficit: expected serum potassium minus measured serum potassium multiplied by ICF, and the ICF is assumed to be 40% of total body weight. Okay, total body weight. Okay, now how to correct potassium. Okay, usually for a serum potassium value 3 to 3.5, oral correction is sufficient. Okay, you can go for an oral correction, but if the patient is symptomatic and serum potassium is between 2.5 to 3, or if the serum potassium is less than 2.5, in this case you have to go for IV correction. Okay, IV correction. Okay, now some general principles for have to be careful in case of potassium correction. The first one is avoid potassium correction in glucose containing solution. Okay, because this glucose in the solution will stimulate insulin secretion. This insulin will cause intracellular shift of potassium. That is why we have to avoid glucose containing solution for correcting potassium. Okay, second one is potassium is an irritant. Okay, will irritate. Potassium is irritating endothelium. Okay, so there is a chance for phlebitis if you are giving the potassium through the peripheral line. So there is a limitation in peripheral line. Okay, in peripheral line you can give a maximum of 40 milliequivalents and it should be diluted in 500 ml NS, and the infusion rate should be infused over 4 to 6 hours. Okay, because the potassium is toxic to endothelium, so it should be infused at a slower rate and should be diluted in 500 ml NS with, you can give a maximum of 40 milliequivalents in 500 ml NS and infused at a rate of 4 to 6 hours. Okay, but in central line you can give much more higher concentration, but in central line also you can go up to a correction of 20 milliequivalents per hour. Okay, never exceed more than this, never exceed 20 milliequivalents per hour. Okay, and you have to monitor the patient by taking ECG. Okay, ECG monitoring should be there while correcting the potassium. Okay, and also in majority of the cases the potassium depletion may be associated with hypomagnesemia. So you can give a magnesium at a rate of 20 to 60 milliequivalents per 24-hour magnesium correction. Okay, this is the management of hypokalemia. Okay, hope you enjoy the session and kindly do subscribe my channel if you are interested in emergency medicine related videos. Okay, thank you for watching.